Good morning, colleagues. Good day to you and happy Friday to everyone. Thanks for joining us for this webinar on improving quality of care, telemedicine and virtual care during and post-COVID-19. I am Dr. Rosamond Adams, the Director of the Pan-Caribbean Partnership Against HIV and AIDS, PANCAP. This is a PANCAP PAHO webinar, and I extend a warm welcome to you on behalf of the partnership and on behalf of the Pan American Health Organization, PAHO. We're pleased to be able to join us, to have you with us again on these ongoing webinar as we continue to share knowledge that is current, evidence-based, and relevant at this critical time. As of yesterday, the 13th of August, the World Health Organization reported a cumulative total of almost 20.5 million cases of COVID-19, with 50% or almost 11 million cases in the region of the Americas. Many countries have instituted measures to contain the spread of COVID-19, impacting our lives in many ways, including how we deliver healthcare. Many of us have been talking about the new norm and are beginning to think through what this means for us on a personal level and also on how we deliver healthcare. As practitioners, how do we practice medicine and how do we continue to deliver programs in the health sector? The concept of telemedicine or virtual care is not new, but during the COVID-19 pandemic, it is more relevant and useful. More than ever, more consultations are done virtually, and there is greater use for virtual platforms and modalities in delivering healthcare during COVID-19. In the next hour or so, we will be discussing key elements of telemedicine and virtual care, and we'll share Guyana's experience in telemedicine for the last 2 years. But before we begin, I just need to draw to your attention two very important housekeeping issues. First of all, your mics are muted. If you have questions as the presentation progresses, please type them and submit them in the question field on your webinar panel. We will address these questions in the question and answer segment at the end of the presentations. Secondly, we are recording the webinar and we will share the recording on the PANCAP website and social media platforms for the benefit of those persons who could not have attended the live session today. You will receive a post-webinar evaluation. Please complete this as it will provide us with feedback on improving our webinars, and also you're able to download a certificate of participation for participating in today's webinar. I have the pleasure to present to you today three esteemed presenters who have been working in the field of telemedicine and virtual care. Our first presenter in today's session is Dr. Times Gen, who is an infectious disease physician and a professor of medicine at the Mayo Clinic, where he has established and currently directs the Mayo Clinic HIV program and the Mayo Clinic Center for Tuberculosis. In addition to clinical responsibilities, he has been actively involved in education and research with the Mayo Clinic. Dr. Times Gen is the editor-in-chief of the Clinical Journal of Tuberculosis and Other Microbacterial Diseases, Mayo Clinic Infectious Disease Board Review Book, and Fundamentals of Global HIV Medicine. Ladies and gentlemen, I welcome our first presenter, Dr. Times Gen. Dr. Times Gen, over to you.
Good morning, everyone. I hope you can all hear me well. It is my pleasure, and I'm very grateful to Dr. Adams, Dr. Singh Anthony, and PAHO for the opportunity to participate in this conversation and exchange of experiences and knowledge. My talk is a general overview of virtual care and telemedicine. And the learning objectives of I'm trying to make sure that you can see my. So the learning objectives of my talk are that by the end of this talk that you will distinguish between the different terms that are used to describe remotely delivered care. You will be able to describe the various types of virtual care and articulate the benefits, disadvantages, and barriers to an effective virtual care program. I think it's important to come to a consensus about what the different terms mean. And I will tell you what I think they mean, and it would be interesting to know if people understand these differently, perhaps at the question and answer session afterwards. So to me, the broadest encompassing terminology is digital health. And digital health is essentially the application of technology to anything health. So it can be remote, it can be face-to-face, it can be mobile, it can be video. Basically, any application of technology to health goes underneath the term digital health. And so this is the broadest term, in my opinion, and all the other terms fall under it. Telehealth, as the name implies, tele, at a distance, is essentially the delivery of care through a non-face-to-face encounter. And virtual care is essentially the same as telehealth, in my opinion. Sometimes telehealth may go beyond just delivery of care and may have other health-related aspects of it, but both telehealth and virtual care denote a non-face-to-face encounter to deliver healthcare. Telemedicine, to me, implies a synchronous, synchronous virtual care. In other words, the provider and the physician are linked in time to that encounter, so that the provider actually is able to see the patient and in real time participate in the care of the patient. Virtual visit is a broader term in my mind than telemedicine, because the virtual visit can be synchronous or asynchronous, and I will explain what those terms mean, but I think people understand what they mean. And so it may be in real time, or it may be at a later point than when the consult or the visit request was put in. E-consult is similar to virtual consult in that it is a so virtual consult is different from a virtual visit in that it is a specialty opinion or an additional opinion on top of primary care that is taking place. E-consult is similar to a virtual consult, but the e-consult implies that it is asynchronous. It's not in real time. Mobile health specifically means that the technology that is applied to the non-face-to-face encounter or to the encounter is with the use of mobile apps. So these are the various definitions of what we understand by some sort of a technology supported healthcare. The modalities are synchronous, asynchronous, and remote patient monitoring. Synchronous means that it is real time, whether it is an audio or a video interaction, whether it is done through a mobile app or a desktop computer. The interaction is in real time. The patient and the provider are linked in the same time frame. Asynchronous implies that time linkage is not there, that it is at different times. So this is where store and forward technology applies, where, for example, patients can post messages and questions to their providers through patient portals, and the provider then accesses those questions and responds to those messages at a later time. So it's not in the same time frame, it's not real time. Remote patient monitoring, which can be synchronous or asynchronous, means that there is a direct transmission of patients' clinical data, whether it is vital signs or responses to questions are collected remotely from a patient. And I will give examples of all of these modalities and some of the various types of virtual care. So why is virtual care necessary? So as Dr. Adams pointed out, virtual care or telemedicine or telehealth is not a new discovery in the COVID-19 pandemic era. It has been something that we have been using and we have been increasingly using even before that. But what the pandemic has done is that it has heightened the need for the use of technology to provide care to those who need it, while at the same time protecting patients and protecting healthcare workers. And what the pandemic has done for us as well is that it has removed some of the pre-existing barriers to telehealth or to telemedicine. And those are, for example, in the United States, are the need for medical licensure in the state where the patient resides to be able to provide telemedicine or telehealth care. Reimbursement has been an issue. And so in this public health emergency of the COVID-19 pandemic, those barriers were removed. And so we were able to do much more of that as a response to the public health emergency. And I think the removal of those barriers will continue to persist in some fashion, at least after the pandemic is over, which bodes well for advancing telemedicine, telehealth, and virtual care. So during COVID-19, telehealth has helped us in triaging patients with symptoms so that we can distinguish between those who need to be hospitalized as well as those who need to stay at home, and where we can institute remote surveillance for those at-risk patients. What this does for us is that it has minimized the transmission to patients and the public, because the patients do not need to be physically present in a waiting room, in a clinic, in the emergency department, in the hospital. This also keeps healthcare workforce safe, and so minimizes the direct contact between physicians and patients, as well as between healthcare staff themselves. Where there is no expertise available on hand, it has allowed for frontline physicians, such as primary care physicians or emergency department physicians, to be able to consult with specialists such as critical care specialists and infectious disease specialists. Even through a pandemic, life goes on, and there are other medical issues besides the COVID-19. And what telehealth has also done is that for low acuity non-COVID-19 medical issues, it has enabled for those to be handled remotely, and again, keeping patients and keeping the healthcare staff safe. For people who have chronic conditions such as diabetes, asthma, HIV, it also has enabled the continuity of care without the necessity of having those patients come in frequently into the healthcare system. For those physicians who are not physically able to provide delivery of care, it also has enabled them to function remotely to provide their input and expertise. And where there has been a strain on the healthcare workforce, and there has been it has overwhelmed the healthcare systems of many countries. So it has been possible to shift and assist physicians in other places. So, for example, within the United States, if there was an overwhelming situation in New York City, then some experts in other parts of the country could actually assist in providing some input and some care for people who are actually in state, and the physicians and the other providers in New York City. This is just an example, but that's happened in other countries as well. The benefit to the patient, the benefits to the patient are obviously the convenience of it, the ability to continue to engage with the clinical team, and the cost related to healthcare. That cost has to do with, for example, not minimizing the away from work transportation and other things, and this has helped in improving satisfaction with the clinical care. The benefits to physicians are very similar to the benefits to patients. So geographical barriers have been overcome so that providers and physicians can consult with other providers and physicians. Providers can provide care and extend their reach to their patients. Transmissions of clinical data, images, and videos have allowed to have the necessary input to provide a diagnosis or a treatment plan. Multiple members of a team can interact and collaborate in patient care, minimizing the cost and minimizing transportation issues and minimizing time issues. And the other 2 points I've already spoken about. The health system also benefits in that delivery of care is maintained, delivery of care is maintained in a low-cost way and then a convenient way, both to patients and the healthcare system employees. The practice options have become flexible because of the availability of telemedicine, so that extended hours could be utilized, including weekend hours. We've talked about the expenses. We've talked about patients who may be lost to care because of all the different barriers, including cost, geographic barriers, and so on, now are able to be maintained in care because of the availability of telemedicine. In essence, what telemedicine or virtual care has done is it has removed the barriers of time, and the barriers of distance, and the barriers of a lack of adequate expertise locally. And so continuity of care is maintained in chronic conditions, low acuity care is provided without making patients come to an emergency department or to the clinic. Access to primary care as well as specialty care is timely. Where there are no specialists on hand locally, now they can be accessed remotely. Multidisciplinary interprofessional teams can work together on a case and provide a more comprehensive and cohesive treatment plan, and I can give examples of that afterwards. In addition to the geographic barrier, well, the geographic barrier includes transportation barriers, cost barriers, and we've already talked about geography, which includes rural locations where there are lower number of clinics, lower number of hospitals, lower number of medical care providers. So let me explain a little bit of the Mayo Clinic system. Mayo Clinic has 3 campuses. One, and the original Mayo Clinic and the mothership is the Mayo Clinic campus in Rochester, Minnesota. Then there are 2 additional campuses, one in Florida and one in Arizona. In addition to these 3 campuses, there is what we call the Mayo Clinic Health System. And this graph, the top left map shows the Mayo Clinic Health System. And the Mayo Clinic Health System is a network of about 60 facilities, hospitals and clinics owned by Mayo Clinic, wholly, fully owned by Mayo Clinic, which are present, which are located in Minnesota, Wisconsin, and Iowa. And this is an example of where the expertise which is found in Rochester, in this particular case, is the critical care medicine expertise, which is found in Rochester, can be used to enhance the delivery of critical care in a lower level health facilities. And so the Rochester facility would be the command centers, and then there will be smaller ICUs in various locations within the health system, which are connected 24 hours, 7 days a week through high definition audio visuals, which are real time and bidirectional, so that the experts at the command center can contribute to the care of patients in the ICUs at the lower level facilities. So this is tele-ICU. There's a number of other telehealth programs. The acute care telemedicine program provides very quickly specialty consultation and guidance for medical and surgical emergencies through a live video communication, similar to what I just showed you for the tele-ICU program. Now in the Mayo Clinic Midwest region, because of the tele-neonatology program, 100% of newborns in that system have immediate access to a neonatology expert, which is much, much better than what the situation was before the tele-neonatology program. Telepsychiatry service with the same concept is depicted on the lower left, and then tele-stroke program, again providing expert care, specialty care remotely. Left top is an example of a virtual consult where our thoracic surgeon here is providing his expertise through a video visit. Below that is the Mayo Clinic Photo Exam app, which allows clinicians to capture the photographs and videos of patients using a mobile device, the iOS mobile device. Then these images are securely transferred to the Mayo imaging systems, and they're stored and made available whether locally or remotely for viewing and for further action. The the right upper picture is an example of an e-board, which is an opportunity for a multidisciplinary team to discuss complicated, complex cases, and through a video technology. What you see in that picture is a tumor board where oncology cases are discussed. The picture at the at the bottom right is a remote patient monitoring system where a digital tablet is provided to a patient, and that is along with a Bluetooth-enabled blood pressure cuff, pulse oximeter, and weight scale and thermometer, which all then remotely provide, whether in real time or in a store and forward modality, to a central repository where it would be reviewed and appropriate actions taken. This remote monitoring system also has the ability to provide responses to certain questions, so that in addition to the vital signs and the clinical data, you would also have patient responses to add to the information obtained. This is telecardiology, where you would have a central place where expertise is available and can provide input into, for example, EKG readings. At the bottom is a mobile app that actually can provide a clinical grade EKG reading with that additional small device that you can see. On the right side, the Mayo Clinic has a program where artificial intelligence is used to analyze cardiac ultrasound input and see and try to understand what the impact as well as the evolution of heart involvement is in COVID-19. At the bottom is a way that one can actually, in a non-invasive way, measure blood potassium through a signal processed single lead EKG acquired through a smartphone. I would like to present finally an asynchronous program that we have been conducting for some time now, existing pre-COVID and going through the COVID era and continuing after COVID, which is the point of care CME for HIV, tuberculosis, and associated conditions. So what this does is clinicians all over the world can submit through email specific questions that they are facing on patients that they are taking care of. This question comes to our system and is then assigned to a subject matter expert. The subject matter expert, the consultant, looks at the question, does what is necessary to respond to the question, and responds not directly to the clinician, but to the panel of experts that are part of this program. The experts will weigh in and provide additional input on top of what the consultant had determined is as a response to the clinician, and then the total, the combined input is then transmitted back to the clinician, and this is done within a period of 3 to 5 days within the receipt of the query. And for participating in this transaction, the clinician who posed the question receives a CME credit. And so what it does is that we provide a free service a free opinion on complex cases to clinicians globally who are in need of such opinion. And because the opinion that we provide is accompanied by the evidence basis for that opinion, and that is provided to the clinician. So this entire interaction is then qualifies for what we call a point of care CME, and the clinician gets a CME credit. I just want to point out in conclusion a few things. So for telemedicine or virtual care to take place, there need to be a few things in place, and these things include reliable connectivity, cybersecurity. The interaction has to be HIPAA compliant. There has to be documentation of the interaction and the encounter. And so there are things to think about in this along these lines, and there are some perceptions and perhaps some myths and perhaps barriers to address. So, for example, there is a perception that patients prefer in-person interactions with their physicians. That might be true, but this may not be entirely true. And I think our experience and the collective experience had been that when done properly, the telemedicine or virtual care interaction is very well accepted by patients. We just have to make sure that which patients are and which cases are best situated for a virtual care program rather than in-person program. Example of this is, for example, a new patient may be less situated for a virtual care program as opposed to a patient who has a chronic condition and has been followed by you. And so the virtual care actually enhances the already in place patient-physician relationship and care. The lack of technical knowledge to integrate telemedicine services, I don't think this is just a myth, and this is actually a real issue and has to be taken into consideration both on the provider side as well as on the patient side. The inability to conduct a physical examination in telemedicine may be either a reflection of the sophistication of the telemedicine platform that you're using, but it also may be that the providers may be a little less diligent about the physical exam issue as opposed to when they see a patient in person. That has to be taken into consideration. The patient lack of access to reliable internet connectivity is a big issue, and it will feed into the health disparities that are already present outside of telemedicine and virtual care. Patients may be there may be a lack of confidence in the safety and security of virtual care by both the patients primarily, but also from the provider standpoint. So we need to make sure that that is well addressed and taken care of. And the next point, the patient's perception of poor quality of care in telemedicine visit is the same issue as patients preferring in-person interaction. I think this can be something that can be resolved with proper attention, and if done properly, patients will accept telemedicine as a proper care. The certain subgroups of patients, whether it's older patients or others, may be excuse me, may be unable to or unwilling to embrace telemedicine, and this also this should not be dismissed outright. This should be addressed properly, and making sure, understanding what their concerns are. Is it the connectivity? Is it the confidentiality? Is it the discomfort with technology? I mean, those things have to be addressed and resolved. So the issues to ponder in general are to maintain the patient-physician relationship, which is crucial for providing good care. Make sure that the remote non-face-to-face encounter does not result in depersonalization of the patient-physician relationship. One problem that I see is that there is sometimes a perception from the health system and from administration that the time required to conduct a telehealth encounter is not the same as the time for a physical encounter. I think this is a mistake. So if inadequate time is allocated and just additional work is added on without this to physicians and providers, I think this will become a problem. I see that as a big problem. I've already talked about a reliable telecommunication and connectivity infrastructure that is necessary on both the side of the health system as well as patients, and that will widen health disparities if not addressed. Privacy, confidentiality, and disclosure issues are real issues, and they do need to be addressed and resolved for an effective virtual care program. So oftentimes, this is what work looks like for me in this COVID-19 era, and I'm sure will continue after the COVID-19 era. There's a lot of benefits, and I'm a very enthusiastic proponent of telemedicine, digital health, virtual care, and so on, but with a full acknowledgement of the issues that need to be resolved for this to be effective. So I thank you for your attention. Look forward to listening to the other presenters and the question and answers at the end. Thank you.
Thank you very much, Dr. Temasban, for that very detailed presentation on telemedicine and virtual care during and post COVID-19. I particularly like at the end how you sum up the points to ponder upon, because I know that all of us recognize that telemedicine plays an important role in bridging the gap or in supporting where the COVID-19 measures will have caused disruption in healthcare. And so by using these virtual medium, one can still have access to care. However, there is still the feeling that the physician-patient interaction has to be physical. There is also the feeling that there has to be the physical examination of the patient in order to arrive at a proper diagnosis and so forth. And issues around your medical data, where is it stored? Will someone intercept this data while it is being sent remotely and so forth? But in the interest of time, we will then move on to our next presenters, and I'm sure that in the question and answer segment, some of these issues will be raised there. Our second presentation is a joint presentation that will be done by Dr. Baldev Singh and Dr. Shonda Wins. Dr. Baldev Singh is currently a medical registrar heading a team within the internal medicine department at the Georgetown Public Hospital Corporation, and she holds a Bachelor of Medicine, Bachelor of Surgery degree from the University of Havana, and a Master's in Internal Medicine, Infectious Disease from the University of Guyana, and an MBA in Hospital and Health Administration from Bedfordshire University, UK. Dr. Shonda Wins, who is an accomplished physician with more than over 9 years of experience treating patients with various chronic diseases as well as emergency conditions. She is a highly knowledgeable medical registrar in internal medicine with over 2 years of experience in cardiology and special interest in maternal medicine. She holds a Doctor's of Medicine degree from the General Medicine Yugoslav State Medical Academy, Masters of Medicine from the Internal Medicine and Infectious Disease Department at the University of Guyana, and a Masters of Business Administration in Health and Health Services Management from the University of Bedfordshire in the UK. Dr. Singh and Dr. Wins, over to you.
Good morning, everyone. I'll start off the presentation today. Today, we're going to tell you a little bit about our experience with implementing telemedicine in Guyana. And to start off, I just want to give you a little background of how this all started. Telemedicine started off as a quality improvement project, while myself and Dr. Singh were residents of the entire program. We want to do something that would have quality of patient care, not only in our department, but something that and this is how we think about it. The objective we're going to we will describe the telemedicine. We will discuss the outcomes of the implementation or future direction.
Dr. Sandra, I think you just need to come a bit closer to the microphone. We're not hearing you too clear. You may need to come a bit closer to the mic.
Okay, can you hear me clearly now?
Colleagues, please bear with us while we try to get the audio sorted.
Are you hearing me?
Yes, we can. Please go ahead.
We're hearing you now.
Okay. So, prior to starting off our project, we identified.
Dr. Wins, sorry to disrupt again. You'll fall off again. Can you try to speak closer to the mic? We're not getting you.
Hi, are you hearing me now? Hello?
Dr. Wins, it sounds as if you're far away, so I think you may need to come closer to the laptop, or if you have an earpiece, you can just plug that in and use the mic on the earpiece. It sounds as if you're talking to us from far away, so we're not hearing you clearly.
Can you hear me now?
That's perfect. That's perfect. We're hearing you very clear now.
Okay, sorry about that.
Thank you.
As I was saying, we identified a few key issues within our medicine program, as well as in Guyana, that we thought could have been addressed with implementing telemedicine here in Guyana. And one of the key issues is human resource. Now, this is actually a photo of some of our internal medicine residents and registrars at the medicine department at Georgetown Hospital. Now, these are some of the people who would have been involved in this project and the people who were actively involved in sending cases using our telemedicine platform. Now, up until 2013, the World Health Organization estimated approximately 2 physicians per 10,000 persons in Guyana, while in the rest of the Americas, there were approximately 22 physicians per 10,000 persons. So it was obvious that lacking human resource was an issue, and this was one of the things we wanted to address. Secondly, access to health care. The population in Guyana is sparsely distributed over an area greater than 200,000 square kilometers. Now in Guyana, we have 6 regional hospitals, 22 district hospitals, and about 100 health centers and health posts together. Georgetown Public Hospital Corporation, where we work, is actually the only tertiary care and training hospital in the country. And for some people, travel time can exceed over 24 hours to see a specialist at this institution. Thirdly, we looked at our program curriculum. Before 2017, we had 1 full-time on-site internal medicine faculty member. And in 2017, by 2017, we actually had no full-time faculty member on site. And this made it very challenging to provide direct supervision and mentorship to our doctors. After reviewing these main issues, we decided that we were going to set some objectives to implement telemedicine in Guyana. And these objectives were to enable access and decentralize internal medicine expertise through Guyana. We wanted to provide our medicine senior registrars and residents the opportunity to discuss and review complex cases with McMaster subspecialist faculty. And thirdly, via these discussions and feedback on case presentations, the consultant faculty would be able to identify some learning objectives, also to encourage critical thinking and clinical reasoning with our residents. So in order to do this, we have a web-based telemedicine provider. We used Collegium Telemedicus. How this worked was our residents and registrars would be able to send non-urgent queries to specialists at McMaster University. When we send over information using this web-based provider, we were able to include details such as a history, investigations. We were able to upload images such as CT scans and chest x-rays. We were able to include an assessment in our plan, and then we were able to identify or select a clinical question that we wanted to ask the specialist that we wanted to get feedback on.
Good morning, everyone. Initially the primary GPHC Georgetown Public Hospital and McMaster University, and then after our proposal was accepted, Ministry of Public Health and PAHO came on board as part of the primary stakeholders for the telemedicine project. So in terms of the project design and timelines for the telemedicine proposal was accepted, a protocol agreement and a MOU was designed and implemented in August 2017 between the various stakeholders. Then a needs assessment was done at the regional hospitals in September 2017 with a visit from the faculties from McMaster University and the residents from internal medicine at Georgetown Public Hospital. After this was done, a pilot phase with training at the internal medicine residency at Georgetown Public Hospital was done in October 2017. 2017 and August 2018, the pilot phase continued with the GPHC IM residents and registrars consulting with the McMaster subspecialties, sending cases and referrals. Between this period, we had 2 focus groups to get feedback from what was happening. The first one was done in March 2018. Then the second focus group was done in July 2018. And then the second phase of expansion was done to the various regional hospitals that were identified before and the health centers in November 2018. So from the focus group discussions, what we found in terms of feedback was the pros. The residents referred that they had improved management of complex patients and cases. They were allowed enhanced critical thinking when preparing for submission of cases. They had access to specialists with evidence-based expertise. And they got to learn from specialists, a specialist clinical approach and reasoning towards the complex cases, and also how to organize clinical presentation through informal feedback from the subspecialties and the specialists. So some of the cons that were identified were that sometimes there were delayed responses. And after the second focus group discussion, this was improved. Also, sometimes it can be time consuming because of the case can be very lengthy and long. And also technical issues were identified with the web-based. And this was improved after we implemented an app and we had improved Wi-Fi accessibility at the Georgetown Public Hospital. So in terms of our future directions, our plan was to decentralize the internal medicine expertise and expand to the regional hospitals that were identified in the initiation, partner with the Ministry of Public Health and PAHO to acquire and install the necessary infrastructure that was needed, and also to develop national consultation services, linking the regional hospital providers to the various IM specialties and subspecialties. So how we plan to in the future to move forward was to have the GMOs, or the governmental medical officers at the various regional hospitals and community health centers send their cases to the internal medicine and registrars and residents at GPHC, and we look at the cases and we can give them back an answer if we feel that we have the necessary tool to do so, or if not, we need further advice from the subspecialties. We would send the cases to the faculty members and specialists abroad, mostly at the McMaster University. And then the flow would be that this a response to the clinical question, and we contact the government, the GMOs at the various hospitals and health centers in the regions. So from this, what we have identified so far is that from using telemedicine, it's very easy. The initial stages, it's mostly the investment that needs to be done in terms of getting computers and internet access, and also the place to use. It's very easy to use on desktops, and later on we identified Androids as well can be used, especially with the telemedicine app. And we learned that internet access is very essential for the telemedicine project, because if there's no internet access, then we will not have the communication as needed. And we learned as well that physicians buy into the use of telemedicine is key for the development and growth of telemedicine, as they would be the users in terms of sending cases and having responses. Limitations that were found and identified in the focus group as well. We know that if we don't have inadequate access to the internet, and this can be because of lagging of the internet, also not having enough desktops to use, as there were many residents that were using the telemedicine project, and this was identified as a limitation. There was also lack of use by physicians, mainly due to time, as most registrars and residents are very busy, and sometimes they are so busy that they tend to forget to use it. And sometimes, because as the same with the consultants, there is delayed response sometimes. And we also identified that the telemedicine project was only used in non-urgent cases, as most physicians or residents tend to use either WhatsApp or telephone if there is an urgent case. And the response time for our telemedicine was usually between 48 to 72 hours for the non-urgent cases. When going to the regional hospitals, after we set up at Georgetown Public Hospital, some of the regional hospitals visited, we identified that there were lack of infrastructure for setting up of the telemedicine. And one of the main thing was the access to internet and also the computers to be used. We identified also that using telemedicine would be new to some of the physicians, and definitely training will be needed for them to understand telemedicine. Another point we identified was that physicians' motivation is necessary to use telemedicine, as it's easier to make a phone call than sitting and writing or texting. And yeah, so we identified that, you know, phone call is easier than writing or texting. So from this, what we recommend is that when especially going to the regional hospitals, is that we need to identify the potential stakeholders and develop a memorandum of understanding. We need to have feasibility studies and need assessment done, and it's very important, particularly in the remote areas of the country, as there may be various factors that can block the progression of the telemedicine project. We need to train physicians to use the platform and also encourage participation from them, make them feel like they're part of the project and have their buy-in. And also in the future to consider setting up a system that can allow to review both urgent and non-urgent cases. This is our references, and thank you very much for listening.
Thank you very much for that presentation and giving the experience in Guyana. We will now go into the question and answer segment, and I recognize that we are almost close to time. However, we will spend about the next 5 or 10 minutes responding to some very important questions that we have received so far. One of the first questions that we have here is that the participant is asking, in addition to cybersecurity, is there any legal reform necessary to implement digital health? And so I guess we will hear from both the Mayo experience and that of the Guyana experience, if there are any legal reform necessary to implement digital health. And when you're responding, you can turn on your video so that the participant can see and interact with you. Thank you very much.
Yeah, I can go ahead if okay. So I think I briefly mentioned that in my talk, but the short answer is yes. There are legal aspects to telemedicine, and one of the barriers previously had been, for example, a requirement for licensure in the area, in the state that the patient is from, for telemedicine to happen. The legal aspects differ depending on what kind of telehealth or virtual care is given. So as an example, for the point of care CME that we are conducting, there is no legal implication for us, because our communication is not with the patient. We're not taking direct care of the patient. We're responding to questions from colleagues based on the information we receive from them on the case. We don't receive patient identifiers, and what we provide is based on the information furnished, and the clinician posing the question is the complete freedom to act on the advice that we provided.
Thank you very much. Dr. Singh or Wins, do you want to come in here?
Yes. So basically, what Dr. Zami just explained, it's very similar for us, and this is actually one of the reasons we identified a web-based provider for telemedicine specifically due to these issues, because most of the times when discussing patients or consulting with people from far away, we tend to use our telephones to make phone calls or other things like WhatsApp. So to avoid this where it regards patients' confidentiality, and this is one of the reasons we use the telemedicine platform to do so.
Great, thank you very much for your response. We have another question here that is asking about persons who live in remote areas in terms of initiating and getting access to telemedicine or to digital health. And the question is, in terms of the initiation, does it have to be facility initiated, or can the person themselves access some level of e-health, digital health, or access to any of these platforms without being linked or initiated by a facility?
So for us here, sorry, Dr. Zam, okay. For us here in Guyana, we were able to get the platform in the form of an application that can be used on cell phones, or you could just download the app on your laptop or your cell phones. So it doesn't necessarily have to be through the facility. The only thing is that you would have to be registered to use the platform. And that was one of the ways we were communicating with some of the doctors in the remote areas here in Guyana.
Okay, thank you very much for that. So there have been a few more questions regarding remote access and persons probably not having access to technology and so forth, and how do they then get access to this platform. There is a question here that is asking about virtual medicine, and the question is, does virtual medicine open an avenue to commercialize healthcare even more? And if so, is this viewed as an advantage or something unethical? And the participant is drawing reference to say, when persons give their data and so forth, it is stored in these electronic platform and can be used to target persons to access healthcare and so forth. So can it be used as an avenue to commercialize healthcare? That's the question that is coming from the participant. Dr. Temesgun, I don't know if you want to react to this, to respond to this question.
Yes. So it has been used and it is being used to commercialize, if that's the word we want to use. In other words, various healthcare systems and facilities are using telemedicine and telehealth not only to enhance and provide care for their patients, but also to increase their reach and increase their access to other patients in which they may not have accessed before. So there is nothing wrong with that, with the caveat and with the proviso that all the things that we mentioned about the components of telemedicine that need to be in place, and the attention that needs to be paid for how the negative aspects of telemedicine, all of those, with that proviso, I think I don't see anything wrong with the use of telemedicine to expand the reach of a healthcare system or a clinic, but it is being used, and it has been used in the past as well.
Great, thank you very much. Another question we have here is, does telemedicine make healthcare delivery mechanical for patients and take away from the personal nature of a visit and diminish the setting to empathize? I know that in the presentation, these were some issues to ponder on in terms of the personal interaction that we're accustomed to in medicine. That you must see the patient in front of you, and you must be able to speak to and to be able to touch physically the patient. So I guess the concern here is, does telemedicine make healthcare delivery mechanical and takes away from the personal interaction and diminish the ability to empathize with your patients? Any one of you can take it.
It has the potential to do so, and that's why I put it in as issues to ponder. So you also have to be able to select which conditions and which patients are best suited for telemedicine. So for example, if you have a patient with a chronic condition, an established relationship, and you use telemedicine to intensify the encounter with the healthcare system to better control the chronic condition, and there is a physical encounter interspersed between the non-physical, non-face-to-face encounter, I think that would be like a very appropriate use of telemedicine. So one of the situation mentioned previously, how people in rural locations would access the telemedicine outside of a facility. I think that's where you have to be careful, where there is no relationship established beforehand, and the only encounter from the get-go has been only a telemedicine encounter. So you have to be very careful that it doesn't become mechanical. So the potential for that is real and needs to be taken into consideration.
Thank you very much. Any response from the other presenters in terms of the question that was posed? Any real life experience in terms of implementation and any feedback from patients as to it being becoming mechanical and the ability to empathize?
So the difference with us here and our experience is that it's not that the patients were being managed directly by someone abroad, but people here are actually being coached in terms of an approach to that patient. And therefore, we still have that physician-patient relationship going here, as opposed to just directly telemedicine with a physician and a patient. So we would not have had any of that sort of feedback. We do, however, let our patients know about our communication with the specialists, and they're usually happy to know, or they welcome whatever is it we do for them.
Great, thanks. And I think that these are very important to be clarified, because when one speaks of telemedicine, I think that there is a notion that they believe that that the interaction from the get-go is totally virtual, and therefore the whole physician-patient interaction is lost, and there are concerns about that. But But I think that in the presentations, we did see that there is the personal physician-patient interaction. However, where there are gaps or where telemedicine can be used to even facilitate certain types of services that may not be available, then the physicians can use this to really enhance the patient's care and access and the patient's access to getting that type of care that they may require. I have another question. There are lots of questions that we've been getting, and I think that this issue of telemedicine is becoming so important now as we look at how do we ensure that care is continued, and how do we ensure that care is delivered and reach those who are in remote areas as we face these lockdown measures from COVID-19 and the disruptions from COVID-19 as person try to limit personal interaction and social distance during the time like these. One of the question is for the colleagues in Guyana, and it goes that the Guyana presentation spoke to training of doctors. Are there any plans to include other team members, for example, nurses and other healthcare workers in the training program?
Sure, we wanted to have the internal medicine first, and then we plan to include the other specialties such as OBGYN, general surgery, and so on. And also the nurses, because some of the health facilities that are located in the remote areas just have like medics or nurses alone that are working there. So definitely we had envisioned in the future to include these other health workers as well.
Great, thanks. And while we have you on, with respect to private practice, one of the questions is, are there any consideration or recommendations for how private physicians or private practice can liaise and benefit as well and contribute to the system? So that is the inclusion of private physicians or private practice into the whole integration into the telemedicine initiative that you have.
Yeah, it's definitely something that can be added onto the platform. We haven't really put much thought into the private practice area, but definitely something to think about and can be added.
Great, thank you very much. We're running, well, we've run out of time. We're way over time. I'm going to ask the presenters to just wrap up, having heard the questions, having heard the different presentations, to take just 1 minute to wrap up and to give their final takeaway. There are many questions that we still have online coming in. If we have not responded to your question here, then we will reach out to you and via email and be able to provide some response to your questions. So Dr. Temesgen, I'll invite you first to give some final words, and then I'll invite Dr. Singh and Dr. Wins.
Thank you very much. First of all, I'd like to say that I've enjoyed the webinar, and it's been absolutely wonderful for being able to participate in. A general remark: digital health, telemedicine, telehealth, virtual care are here to stay, and they are of immense benefit to all involved if undertaken in a serious, thoughtful, and systematic way, addressing the issues that were raised by the questions at this webinar, as well as some of the issues that I and the other presenters brought up. So ensuring that security, confidentiality, privacy, patient-physician relationship, and all of those things are addressed and undertaken. I would like to again bring your attention to the program that we have ongoing, and I think it would benefit clinicians both in Guyana and in the region, which is the point of care CME program. That is for that's not facility based, but can be facility based. It is also for private practitioners, so clinicians can directly access subject matter expertise in HIV, TB, and associated conditions, and get not only useful information to apply to their patients, but also receive a CME credit from the Mayo Clinic School of Continuous Professional Development. So thank you again, everybody, and I'll listen to my colleagues' comments.
So just something to take away from us here in Guyana is that, you know, when you're living in a resource limited setting, you're working in a resource limited setting, you have to take into consideration things that are needed in order to implement such programs, such as telemedicine. So it's very important to look far out and see what are the things that are needed and a needs assessment, and be able to meet these demands in order to implement something such as telemedicine to improve patient care in remote areas.
I would like to add that the physicians using the telemedicine project app is very important because they play the important role of using it, and we need them to understand that, you know, it helps patient care. Sometimes we become like programmed on what we do, and we may not seek advice. But it's important to know that there, you know, if you have the telemedicine, you can use it to improve patient care. I would like to thank you for giving us the opportunity to present our experience in telemedicine in Guyana. Thank you.
Great. Thank you guys very much. I think that we really had a good set of presentations and questions. Even as we wrap up, we're getting more questions coming in. We may have to have another session, a more interactive session instead of presentation, but you know, very interactive session where we discuss, you know, what are the on the ground challenges, and also what are lessons learned, and what can other countries do, learning from the Guyana experience in terms of telemedicine, and really in the era of COVID-19, to show how this is contributing to improving the delivery of healthcare, or even strengthening healthcare delivery in areas where there are challenges. So again, on behalf of PANCAP and also on behalf of PAHO, we thank the presenters, and we also thank you, the participant, for being part of today's session. We will send the presentations to you via email. As a reminder, you will receive a survey at the end of this this session. Please, it's a very short survey. Please fill it in as we use this information to strengthen and to improve on our future webinars. I also encourage you to also download the certificate of participation. I know many of you would have reached out to us asking if you do get a certificate of participation. There is a link that will allow you to do this. Please continue to stay engaged with us and visit us on our website at pancap.org. Our website provides information on HIV and COVID-19. We also host the COVID-19 dashboard, where you can get present daily updates on new infections that and so in the Caribbean region. Our dashboard is updated daily, and so the information, the COVID-19 information, is current and is up to date. Visit the COVID-19 webpage that is also on our website, and we also have a number of guidelines, research articles, videos, posters, that are available on our website for use and for download that can be displayed in your clinics and in your areas of work. We encourage you to continue to follow us on our social media platforms on Facebook, on Twitter, and on YouTube, and also on Instagram. We also recommend that you visit the PAHO website, where you can find a wealth of resources on COVID-19, and also do follow PAHO on their social media platforms for daily updates on policies, guidelines, protocols, and data with respect to COVID-19 and a number of other health issues, and also the PAHO WHO press briefings that are done regularly on COVID-19. So once again, I thank you very much. Continue to be safe and stay informed. Have a good day, everyone.